Welcome to AETCM, the Emergency Medicine channel. Shall we, sir? Sir, one 5-year-old child came to here with alleged history of trauma. His history is like he fell from a chair, which is up to normal chair of 1 meter height, while he trying to stand out from the chair. Followed by from history from mother, he had a like unresponsive for 10 seconds. Later he becomes alert and is normally performing, and followed by his complaining of nausea and headache over the right side. On arrival to here, assessment of 10-second assessment by PAT triangle, child was alert, conscious, not drowsy. According to respiratory effort, normal respiratory rate, and is not use of any acid muscles of respiration. And appearance wise, child is normal looking. There is no pallor, sinuses or mottling. On initial primary survey, airway was patent. There is no gurgle secretions. On breathing part, respiratory rate is 18 respiratory rate, with saturation was normal. And there is bilateral equal air entry. Circulation parts, BP is 160, pulse is 100 per minute. And disability was Jesus is full, and people is 2 millimeter bilaterally equally reacted to light. Exposure temperature was normal.
Okay. Cervical spine?
Cervical spine, no tenderness.
No tenderness. Okay. So we have a 5-year-old boy who had a fall at home. Okay. From a chair. So approximately 1 meter height. And he had a couple of one episode of vomiting.
Nausea,
no vomiting as such. One episode, nausea is there, and he had a brief LOC.
Less than 10 seconds.
Less than 10 seconds of a loss of consciousness. He is able to remember what exactly happened.
He is able to remember.
Okay. So, okay, fine.
Like patient has become unresponsive, like stuck for 10 seconds.
Okay, that is the only thing. Now, what will you do next?
Next, now patient in our ER is fully alert.
Full score. This is 15 by 15.
So we can make a plan for imaging by our Nexus new CT head guideline.
Okay.
With that
Nexus of?
Nice guideline.
Okay.
With that guideline,
there will be certain areas, certain conditions where we need to take 100% CT. There is no confusion. There should not be any confusion. Only thing what we have in our mind, the mechanism of injury, and the next thing is that brief period of LOC and nausea. So these are the 3 things that we need to keep in mind whether a CT is needed or not. But the rest of the thing, the child don't have any evidence of seizure.
Focal neural deficit.
Any focal neurological deficit.
No.
Any base of skull fracture, evidence of base of skull fracture, like a raccoon eyes or a battle sign or a CSF rhinorrhea hemotympanum. That all is not there. And seizure, definitely if that 10 second, if that is a seizure episode, then definitely a CT is warranted. But a brief LOC may be due to that concussion. The initially that impact would have caused him. That might be the reason for that. But if there is a prolonged period of loss of consciousness,
more than 5 minutes is
very significant. So right now in our mind, whether a CT, an immediate CT is needed or not, when you ask me, straight away we can say, and requirement of immediate CT is not there. That's a clear indication. We don't have to say that this patient requires an emergency CT. The only question that arrives in our mind is whether later on CT is required or not. At this moment, we are very sure he doesn't need a CT. Are you convinced with that?
Yes.
Or he needs a CT?
No, sir. With our guidelines, he is not indicated in CT.
Okay.
We can observe the child. If there is loss of GCS within 2 hours of this trauma, we can move it.
We have to, the most important thing is the observation of the child. You have to observe the child for the next 2 to 4 hours. That will be the time frame where any of the worsening can happen during that time. So we have to observe the child, keep him the ED, and majority of the time the parents wanted to take them home. Usual situation, they will tell that 1 hour, 2 hours is over. They will feed him something. If he is okay, you can send him home. And you have to give, the most important thing is the head injury advice. when they should bring back the child. So that advice is the most crucial part of all these things. So what will be the advice that you wanted to give to the mother during that time?
If the child has persistent vomiting,
Persistent vomiting, like it's not one episode of vomiting. They can have 1 or 2 episodes of vomiting is normal. Following a head injury, a mild head injury, it is normal. We can have more than 2 to 3 episodes of head injury, more than 2 to 3 episodes of vomiting, persistent headache. The patient is complaining of persistent headache, multiple episodes of vomiting, any drop in GCS, or you have any other focal deficit that is developing. Okay, then you can say that you have to take an imaging. So that is
otherwise, child with oral anticoagulants,
or anything like a hemophilia child, or any of these things, definitely you need an imaging.
Child have retrograde amnesia. In pre-verbal child is not able to assess that. If child more than 5 years, if there's retrograde amnesia of 5 minutes, CT is indicated.
And again, mechanism of injury is also very important. So mechanism of injury, when you say, okay, this is a significant fall, when will you say when it's a
the dangerous mechanism, more than child, there is 3 meter height. And while pedestrian ways, motor vehicle accident, and pulled out from a highway,
thrown away from the vehicle, or these all of the things definitely fall from height. More than 3 feet height. These all things definitely need a CT. I'm not denying the fact even the GCS is 15 by 15 on arrival, we definitely need a CT
dangerous mechanism of injury.
Dangerous mechanism of injury, we need to go ahead. And the challenge that we face here is an spinal cord injuries. So in a pediatric spinal cord injuries, X-ray, as you know, or a CT might not be as effective because of the, what will be the problem that you will be, because of the fusion. It would have not happened by this time. So the patient can have initially something called as spinal cord injury without radiological abnormality. So that is called as SCHIWORA. SCHIWORA. So you need to keep that in your mind. Maybe you need to take an MRI during that time to understand the spinal cord. But we don't need to do for this child as such. But when you have suspecting a cervical spine injury also, because dangerous mechanism of injury, any focal deficit the child is complaining of, any upper limb, lower limb paresthesia, numbness, or you feel there is any posterior line tenderness is there, then that point of time, okay, you need to think that a CT might not be an effective tool during that time, because a 5-year-old, you need to go ahead and do an MRI. You will get a better idea. But retrospectively, when you look into the adult, when you want to look for an adult fractures, a CT is a very good tool. Never we are going for this X-rays. X-rays, because once you suspect a cervical spine injury, C-collar has to be put on. The best imaging modality will be either a CT with an MRI correlation. Because you want to know the code, edema, all those things, always MRI is better. For bony structures, always CT is better. So that is the description that you need to make in this case. Okay, so we have a child. The crucial points. What is the difference between an adult head injury and a pediatric head injury? There are little bit changes in the guidelines for a CT brain, but what are the crucial challenges that we have in a pediatric head traumas?
Pediatric head trauma, more recent one because of big head more than it is body. Child head is.
Start looking at it from a 6-month-old child onwards. 6-month-old, 1-year-old, 2-year-old, 3-year-old. So 5-year-old, maybe the head size and the body size will be almost the same. But when you look into a 2-year-old and a 1-year-old child, their head will be significantly large as compared to their torso. So when they are having a fall, chance of getting head injury is small. And very frequently they will come from rolling over from the bed, and all those history fall will be very, very common. So parents will be very much anxious, and they will be insisting you to take a CT. Majority of them, they'll understand that this is okay, there is no problem. You can tell them what are the observations that they need, and you can counsel them and you can send them home. But some parents, they will be insisting to take a CT, which is not required for the child at all. Then what are the other challenges?
Sutures are open.
Okay.
Then soft scalp bone is there.
So chance of fractures, depressed, you can have fractures just like our green stick fractures and all those things what we describe in pediatric age group. You can have depressed skull fractures also can be seen, but usually you will have enough space. you will have some, because the fontanel will take time for closure, like 18 months it will take. So 1 year old, 2 year old and all will have some space, maybe 1 year old specifically. So they don't have much of an issue with the fall, and you can easily look in and assess the anterior fontanel. You can teach the parents. When anterior fontanel, usually it will be normally, it will not be bulging up. So it might be slightly depressed. You will be able to compress it. But when it is bulging, you can tell them that is not a good sign. You can ask them to bring back the child to the ED. So these are all the things that you can educate the parents depending upon head injury. Suppose imagine that this patient is having a head injury with a low GCS. How will you proceed next?
Initially, while coming to here, we will stabilize the C-spine with a collar, Philadelphia collar. Then low GCS, if less than 8, we will secure the airway.
I will say in head injury and all, maybe going for less than 8, definitely we will do. But maybe little bit early airway securing will be much better. Maybe you don't need to wait till 8. You can maybe 10, 11 GCS. Specifically when you have a patient, not in pediatric I am saying, specifically adult patients who is under the influence of alcohol and all, maybe 10 to 11 of GCS, chance of aspiration, everything is a little bit high. Maybe you can early intubate that group of patient also in head injury. Okay, then.
Vitals, we will check the vitals.
Most important thing, what is it? What is the most important things that as an emergency physician we need to concentrate upon? As a pediatric age group, the first thing we should know the vitals for that age group. And mostly we need to avoid the secondary brain damage causes. What is the most common causes for secondary brain damage? Secondary brain damage. I am not saying primarily you have an insult. You have an insult to the brain. There is either a subdural or
saturation more than 95.
Hypoxia. Avoid hypoxia. That is what put them on oxygen.
So avoid hypercapnia. Maintain the BP less than 160 or maintain the MAP more than 70.
Mostly I am concerned regarding hypotension rather than hypertension. I'll
MAP more than 75.
MAP more than 65, 70 or 100 systolic, 110 for adult patient. But pediatric age group you have to calculate depending upon the centile and you need to differ. Okay, above you maintain systolic above 70, maintain systolic above 80. So that is a formula that we have. 70 plus age into 2. So at least you maintain the blood pressure above that. 70 plus age into 2 means
hypertension is less than 70 plus age into 2.
So we have to maintain, you should not allow them to go in for hypotension. So that is the next thing then.
In PCO level 35 to 45,
okay.
Hypercapnia and hyperventilation.
Okay. Then next one is hypothermia. Avoid hyperthermia. Hypoglycemia should be avoided. So these are the things that what we need to be cautious about. And whether anti-seizure medication, you can time being you can start, and the most important thing is after 1 week, if there is no further seizure episode or anything, you need to discontinue that medication. No need to continue it you're doing it for your normal seizure patients. So seizure patient, we'll give it for 2 years and then we'll decrease the dose, then we'll see whether there are any episodes or not, and then we'll stop. But in head injury, once the insult is corrected, no need to continue further. So these points are very, very key. So as an ED physician, always remember isolated head injury. It is an isolated head injury we have discussed, but always remember when there is hypotension, you have to look for the most common cause of hypotension in trauma being hemorrhagic shock. So you should not be missing. Just don't get focused upon only the head injury. There can be other organ injuries also, like chest injuries, you have blood abdominal trauma, pelvic injuries, all those things you should be keeping in your mind. But pediatric head injury as such, one challenge that we need to have, majority of the time, you need to have a proper observation of the child. That is what is more required rather than pushing and taking a CT. Taking a CT anybody can do, but denying, not requiring a CT and telling them that is never needed, don't need to expose them for radiation is very important. So you need to educate the family, you need to counsel the family, because parents will be very anxious. They will be requesting you that they went head injury, they didn't do a CT. That will be there. When you are discharging, you have to mention that, you have to put as per these guidelines. There is no indication for CT at this moment. But whenever any of these things comes, they can review back, and at that time we can go for a CT. So that information, that is the importance of these guidelines. These guidelines are basically specifically for pediatric, for us to practice and also majority of the parents will be educated. You can tell them, see, these are the guidelines. As per, that is not required. If you're still concerned, many of them will be demanding, I am ready to pay. So that sort of attitude will be there. So that we can't do anything. So we might be forced to take a CT during that time. But routinely, pediatric head injury, isolated head injuries are easily manageable. Like this trivial trauma and all, we can easily manageable. But one more important thing that I want you to remember is, don't ever forget regarding non-accidental injuries, NAIs. Non-accidental injuries is what? You have a child that is coming to the emergency room. The mother is coming and giving a history. The child had a slip and fall. But you are seeing an injury. The depth of the injury is much more than that. When you are anticipating a small slip and fall, what will you will have some aberrations or maybe mild contusions over the scalp and all, you are anticipating. But you are seeing much more beyond that. The history is not correlating with the injuries that you are seeing. And the next thing, you are seeing multiple other injuries also over the body of different age groups. So you are seeing a contusion which is maybe 1 week old. You are seeing another contusion maybe 2-day old. You are seeing so many other. Maybe there will be some burn marks over the skin. So we can't just keep that away, that the possibility of a child abuse of a non-accidental injury. So maybe they are separated, they are staying with a stepfather or a stepmother. These are all very common scenarios that we discuss for MRCAM OSCE, because UK system, we used to get these cases, but it is not far away that we are going to see such cases also. So we have to be always vigilant whenever you are getting a trauma or a pediatric age group where your history is not fitting into the whatever the injuries that you are looking into. Always keep non-accidental injuries. History is not fitting. There are different age group because the child has been continuing being abused, or maybe continuously being bitten by the father, or maybe or by the mother, or by the whom the patient, whom the child is being taken care of. Maybe both of them are going for work. Someone else is taking care of the child. You are seeing some burn mark. So all those history is very important. When you are not history and your injuries are not correlating, always keep that in your mind, something called as non-accidental injuries. That is one important thing what we need to keep in our mind. Maybe in our scenario, we are not seeing to that extent, but meanwhile, in between, we are also getting those sort of cases. So always aware of this scenario also. Okay, anything else that you want to add?
Then how you discharge our patient is like, if after taking a CT, GCS is improving. After 2 to 3 hours, GCS is improving from it is the 2-point increase to baseline or the pre-arrival state. Then we can discharge the patient. Otherwise, if the parents or the caretakers are supportive to take the patient again to hospital, also we can discharge the patient.
What I'll advise is that whenever you are seeing a GCS, low GCS, keep them under observation for 24 hours. Guidelines will say when a GCS is improving, you can, but the parents will insist that can we go. So that is the usual attitude. When anything is there, we'll bring back the child. They don't want to stay back at hospital, but you can always make a point that whenever there is a low GCS, you have taken an imaging and you have sorted out there is no head injury, majority of the time you can have an lucid interval. So you have to wait for that 4 to 6 hours of lucid interval. Initially there was no CT, will be an early CT you would have taken, but after 6 hours the child is still drowsy. That is the time you need to repeat a CT during that point. The GCS was around 13 to 14 on arrival. You take an initial CT, there is nothing in the CT. You say that that's absolutely fine. You should not be discharging the child. You have to keep them under observation. 4 to 6 hours, the style sensorium has not improved, then you have to take a repeat CT and see for an lucid interval is in epidural hematomas. Okay, fine.
Thank you.
Thank you.